Okay.
Can we hear us on the other end of Zoom now?
Can you hear us now? Thumbs up. Okay, I'm getting shaking heads. Awesome.
All right.
Well, thank you. Be 2023 and after, or 2022 and after COVID with Zoom and all these meetings. This is the first time this has ever happened with me, and I, do hundreds of these a year, so I'm still learning as well. But again, thank you for allowing me to be here. And what I had said is I probably have about a little over an hour's worth of material. But since there were 2 hours set up for here, I'd rather have this as a dialogue. And what I wanted to do was just show you not only your results within the clinical database, but tell you a little bit more about what the CDB is, a little bit more of what children's hospitals are in the CDB. And one of the things that I'm really excited about coming here is also the opportunities for health outcomes type research. And I'm going to show some of my own individual work and potentially just some ideas to stimulate others here for this. And as Todd had said, we're looking at making this more even real time. So what I mean by that right now is if you input your data, you can get the data back within 30 days in arrears. So I know when I used Phys and SPS in the past, I don't know all their capabilities now, but you're getting to about 30 days in arrears. We're working and developing APIs. We're trying to work with as well some of the larger EHR platforms like Cerner, like Epic, about pulling in laboratory made data. So this is administrative data. And it's essentially things that have come off the billing record there. And also we get your laboratory results. I'm going to show you, you can tell for people who ordered a calcium, how you compare for a specific condition, not only to practitioners within OU Children's, but across the country as well. So it can get down to that detail. And I know for people who do outcomes-based research that administrative data, there's a little bit different than other clinical data. However, it doesn't mean that administrative data is necessarily worse, because there's been data for safety that have shown that for comorbid conditions, administrative data picks up more than clinical database. So again, like any data source, there are limitations here. The other thing that we're doing within Vizient is we're trying to build pediatrics to the same degree that we have with internal medicine and adult medicine. Right now, we have over 1,100 hospitals across the US. 1/3 of every hospitalized inpatient touches our database. So what it does is it allows you to say with confidence that there's enough data to run risk models there. And including for pediatrics, and I'll go over the specific pediatric data here. Everything on this is transparent. So you can go and look at the pediatric risk models if you have transitional patients, that you're still caring for patients who are in their 20s based on a rheumatology or congenital heart disease clinics or endocrine. You can still look at that data as well. But what we're trying to do, like I said, is to try to get more and more children's hospitals and build it to the capabilities like we have on the adult side. We're starting a pediatric initiative from our networks next year. So I'm going to tell you some of the adult stuff that we had ran. We're really excited about finally developing the same type of collaboration with other children's hospitals that I know that you can do with SPS, and potentially working with other Phys members. We're developing APIs. We're a Medicare now qualified entity, so you'll be able to get utilization data as well for population health. We also have what's called the Vizient Vulnerability Index, which I'll show, that can look at zip codes of where your patients come from and what their socioeconomic disadvantages are, so that you can potentially look at setting up case management for those particular areas, or if there are access issues. We had one organization at Northwestern use the Vizient Vulnerability Index to locate a clinic in an economically deprived area. So that some of that is already here, some of it is in the future. And so with that, on my first slide, obviously I wouldn't be putting up there the myths if the answers were in the affirmative. And I'm going to go through all of those to assuage differences or concerns. I can tell you, I will tell you, for the risk methodology, every DRG, it's transparent. So it'll tell you exactly what variables met statistical significance. It's a great thing about Vizient CDB tool. There is no black box there. You can look down and see your individual patients. Now, you can't get down to the individual patient level if, to say you wanted to look at Penn State Children's Hospital. They don't allow you to look at other hospitals' individual files. But otherwise, what I'm showing you, anybody who has the CDB could look at OU's Children's Hospital's performance for benchmarking. And again, the data as far as the risk models are there. We partner internally and externally, both with children, hospitals, and adults to rerun these models yearly, so that we like to think that we have the best-in-class risk methodology to help with comparative benchmarking performances. We use logistic regression for mortality, and we use log transform linear regression for length of stay and for our cost models. Some organizations are feeding in real-time data to do risk modeling. I know of some academic centers who are trying that. The problem is that those that are using it, say, for sepsis recognition and getting incoming variables, whether it's heart rate, whether it's respiratory rate, whether it's other clinical variables, the odds of prediction then of sepsis can change from minute to minute, depending on the data. And a lot of physicians have been frustrated. And so some of that work in those organizations have been off-put by a different team, almost kind of like a rapid response team to come and take a look at the patient, see if you want to start, empiric antibiotics, and then what the sensitivity and specificity is. So I wouldn't say yet, although people were looking for more and more data, I think the point here is kind of watch what you wish for, because it could sometimes lead to over treatment, and certainly when we're talking about antibiotics and antibiotic resistance, that could potentially have ramifications not only within the community and the patient as well. So let me move on here. I'm not going to spend a lot of time on the preliminaries. I sent this to Tennille. This is your data. You're free to keep it, to take a look at it here. But I think the thing that stymies us in quality, and believe me, I've been working at an academic institution for 13 years and being a division chief and also working administratively. There's a lot of brilliant people who work at OU. And we all know that we can pick apart different data, that not all data is perfect. The problem is sometimes in our quest for good enough, we aim for perfection, and as a result, never get off our performance improvement journey. The other thing that I've often seen in academic centers is institutes and departments are very powerful, and they sometimes control their own QI initiatives. Sometimes it's siloed in that area. So if they're working on a particular problem that might transcend different systems and service lines, that information doesn't get cascaded out. And as we know, that variation, there's significant variation. And I'm going to show you just something I ran in the hotel room here that shouldn't surprise you, probably won't surprise you, but it still surprises me. In the year 2022 for viral pneumonia, how many percentage of those children get antibiotics? So our point is really to get you to acceptance, to use your data source to do PDSA cycles and then move on from there. And we think, again, through the clinical database, there are enough people that are using it as their source of truth for their quality journey that they're making significant improvement. So when we look at some of the scope of the CDB when analyzing pediatric quality data, we get about 1.6 million inpatients per year for children. And hospital-based ambulatory clinics are an additional 19 million ambulatory pediatric counters. You're not on this particular list, but you contribute about 12 to 13,000 patients. So you're among, the top 10 or 11 or 15 children's hospitals or hospitals that are submitting data. So these could be freestanding children hospital, they could be hospitals within a hospital, or they can be larger centers that are admitting pediatrics. I think one of the important things, and we show some small examples here, you had some pediatric age admissions to the OU side, outside the Children's Hospital in Edmonds as well, took care of a couple children. I've been able to do this and trying to leverage interest at Johns Hopkins, both in Maryland and also All Children's down in Florida, primary children's in Utah as well. And what's interesting, where there's a discrepancy, is that the FIS database is only those children's hospitals. We know that only about 40 to 50% of children across the United States are admitted to children's hospitals. So the advantage to some of those organizations, they could see, for example, primary children's in Utah only admits 40% of their children at the main children's facility. The other 60% across the state are different hospitals that take care of kids. And the discrepancy in difference in outcomes utilization is profound. So if you're only looking at children's hospitals, you're missing about half of the pediatric universe. And those children are different. Now, many of them aren't as sick as usual. But again, if you want to understand reduced variation, and so a child that gets their care under the name of OU Children's Hospital or other children's hospital, you want to make it as congruent as possible so that people don't necessarily see a difference. And it makes it a lot easier for people who are circling around in the system and working at those different facilities. So I think that's important to recognize.
Can I stop you there?
Absolutely.
Because I don't think that really makes a lot of sense for us. We don't have any control over
Correct.
what happens at any of those facilities.
Yeah.
Nor do we have any knowledge of
Yeah.
any kids that
Yeah.
actually stay at those places. So I don't know that that's such a
Yeah,
thing.
that's probably
for
not
us.
germane for you.
No.
Correct.
Yeah.
Correct.
Okay.
And again, I don't know.
Missing something.
Yeah, and in the future competitively, I don't know if, probably not, but anyone who's near you, I saw in the news in the New York Times a few weeks ago about Tulsa Children's Hospital, and
It's St. Francis and
Yeah.
it's a children's hospital. And I don't know why we weren't in that article. I was going to write a letter to the editor. It was really poorly researched. It was an interesting piece.
I would think though that if we have kids, hopefully not many that do end up in that, we have an obligation to care about what happens.
Yeah.
In that. So
As a system, for sure, but I think for us, we don't have any control over any changes or things that they do out there.
I would argue that we would come if we felt that there were quality of care issues. I mean, maybe not in the past, but
It
once.
I guess it would be nice to look just at us as well.
Yeah.
Right.
Okay. No, I don't.
Yeah.
I don't think we have many. that get
Hope
that.
not.
there are a few. I'll show you the data. So this is our Q&A scorecard in our domains and measures. And again, everything here is transparent. Some methodologies, particularly around adults and different companies, use operating margin. That's not really a true Q&A opportunity. Obviously, operating margin is very important, but when you're looking at quality and safety about things to improve, I mean, this is exactly what our data is and what we're looking for. For the risk adjustments, again, we update this every year. We have 72 different pediatric risk models, 26 community risk model groups as well. So some of those kids who are in community hospitals that we capture in our database, they're risk stratified according to the community model. You're under the AMC model there, and you can see specifically, if you went to the CDB, what those models are for length of stay, for cost, and for also for mortality. And this is just an example of the report you would see. Some of these were cut off, but this is the report that you see there as far as the model diagnostics, model method in some of the cases. Now for a pediatric COVID, we have over 10,000. This was run over a year ago. So the numbers are in the tens of thousands. Some for like pneumonia are over 100,000. And so it kind of gets away from the concern that there's not enough volume to represent true risk model. But again, we always welcome, and we've had academic medical centers, we've given them, you know, the data, and they've run background to see based on these statistical methodologies, model methods, and they found correlations between 98 and 99%. So we feel comfortable that the statistics that we're using and the data that we're using on is accurate, or at least reproducible. We have a Q&A calculator, and Christina Prees, who's the AIM or the OQE, we will make sure that, you know, OU Children's is on this, but this is an example of where we used Z-scores, which are like standard deviation, and it basically will tell you if you're anywhere from 1, 2, 3 standard deviations better than your peer group, or 1, 2, 3 standard deviations less than your peer group. So you could put in, and it's also edible, not edible to eat, but editable on the calculator. Whereas if you were doing planning, you could say, okay, if we're not doing well in a particular measure, say for length of stay, for gastroenterology, if we improve our performance, how could we see our improvement in domain ranks? And at least from the adult side, what I've found is they're concerned about the CMS star ratings. Typically, if you change 2 or 3 variables, you can typically see an improvement of 1 star. I think it's very similar, focusing again on the items where you're performing a little bit lower than your benchmark and looking at that to see what the potential benefit would be. Now, the assumption is that there's no difference in rate of change. So if you're improving less fast than other organizations, it may not show up. If you're improving just as fast or faster, then certainly it'll show itself in the Q&A calculator. And again, just the different safety domains here for the PDIs and the NISN, for the effectiveness as well regarding readmissions and the different specific conditions that we take care of, G-tubes and J-tube 7-day revisits there. So again, it meets pediatric specifications. And again, we try to use pediatric clinicians to partner with on our steering committees to be able to help derive some of this, because you just don't want statisticians thinking what's important for clinical practice. So let's look at some examples here. And this again, OU Med, there were only 2 at Edmond. This is from Q3 2021 through Q2 2022. And you could see the number of cases, and we used as a benchmark other CHA hospitals. So again, there's over 500,000 cases just if we reduce our cohort just to CHA hospitals. And there's probably another 500,000 plus who are non-CHA hospitals.
And can you define CHA hospitals?
Children's Hospital Association. They're members of the Children's Hospital Association. There's a specific query. Now, the other important, you raised a great point there. In the report builder, you can elect, even though we have a pediatric Q&A scorecard, and even though we have CHA hospitals, you can elect to compare yourself to whoever you want. If you want to compare yourself to Stanford, Johns Hopkins, All Children's, we're working with Nicholas, Miami's Children's Hospital as well to come into the CDB. You can certainly self-select those as your comparison group. But again, to give the numbers there, we just decided to compare OU with the other CHA hospitals.
Can you
When you
drill
say
down?
CHA hospitals, are you is that all or just those
Yes.
that participate in Vizient?
All CHA. Well, CHA has a relationship with Vizient. So that's a good question. I can't say that 100% of all CHA hospitals are in this database. I think they are, but I'm not 100% sure.
What do you mean? They share only some data with you or some?
No, they have an agreement with us as far as their supply chain, and we supply medicine through sometimes for CHA for their supply chain and also CHA with other administrative agreements. So they don't, it's the hospitals that submit data. It's not CHA themselves that submit the data.
So there's, I don't know, I'm sorry, I still don't.
Can I potentially, now that I can see my, I've been digging into this. So it's a Venn diagram. So you have FIS hospitals, and we'll say FIS specifically. So you have FIS or Organization Central hospitals, and then you have Vizient CDB hospitals. There's a significant overlap, but there are some children's hospitals that are just in FIS. There are some children's hospitals that are just in CDB. But I think that this comparison would be that overlap.
Thank you.
Yeah.
And so again, just as a high level overview, just looking at length of stay, looking at deaths and looking at cost and looking at readmissions. So let's unpack this a little bit. We use ODE ratios. And so there's only two ways to improve an ODE ratio. It's either decrease the observed or increase the expected. So the way that you increase the expected is documentation and coding, telling the story that your patients are just as sick or ill as others across the United States. And it's the same for mortality as well. And when we look at this data, there's three buckets that we ask you to take a look at as far as broad categories. One is documentation and coding. Two is throughput and patient selection. Now, I'm going to show you differences between where children go home without any services and children that might go home with home health versus those that go to rehab versus those who may go to hospice or elsewhere. And there's oftentimes a large delta, a large gap between those children who go home without any services versus those who do. And we see that profoundly in internal, in the adult medicine side, where on average, the adult patients go home in 4 days, 4 to 5 days, but in some rehab, LTAC, SNFs, it might be as high as 12 or 13 days. And there's a 9 to 10 day gap there. And the longer, obviously, that people stay in the hospital, we found that about a third of complications occur after the expected length of stay is supposed to end. And that makes sense. I mean, and that's why we say, although sometimes our patients don't like to hear it, they feel like we're pushing them out, is because the hospital isn't a safe environment for them to be in. But, when I looked at this, I just looked at to say, of those patients who have complications that, did they occur after their expected length of stay? And I found out, almost a third did. So there's a quality aspect to it. More for adults rather than kids is patient selection. So, a 90-year-old who goes for a bowel surgery, should we have even operated them on the first place? And the docs say, well, yeah, I expected this patient wasn't going to make it through surgery. Well, then the question is, why did you, operate, especially if they had terminal cancer and they could have been in, outpatient hospice and not, have their manner of their death be more controlled in that situation rather than being tubed and ventilated and having ethics consults be in place for futile care. That's less of an aspect in pediatrics, but we see it. I can't tell you how many holoprosencephaly kids that I treated that, unfortunately, and they were over a year old, and a decision was made to continue aggressive therapy. So that's less of an issue. And then finally, the third bucket is actual patient harm. The patient safety metrics like the CODIs and the CLABSIs and those type of metrics. So you want to look at all this data, I think, within those three buckets. The cost is interesting. Some organizations give us their total cost accounting so that they can construct an expected revenue per patient. They can construct an operating margin. That's also where a black box exists. You can't see that data, other people's economics and reimbursement. But what we do is everyone's required to put out a CMS cost worksheet. And so we use the CMS cost worksheet to derive our models for costs. Now, there are clearly differences between the costs that are in the cost worksheet from CMS and your true hospital cost accounting. When I was a CMO, I worked with my CFO and said, look, if your cost accounting is saying that we're overutilizing resources, and I see it in the CDB, it's a match. So let's not fight over opportunities. And what I've found was directionally, if you made an improvement in one area, you ended up making an improvement in the other database, but the scope of change was different. So as far as some of the, again, looking at OU Med, you could see the Children's Hospital, how many cases, you could see the differences between different age groups and how it compares to other Children's Hospital Association hospitals. And there, you know, there is a little bit of a difference, not profound, but there is a little bit of a difference there. And we're excluding normal newborns here. And again, so the length of stay is a little bit higher than other CHA hospitals. The mortality index is commensurable with other CHA hospitals. The direct cost index is pretty commensurable with other children's hospitals. Your readmission rate is slightly more elevated for 30-day readmissions. And those are all-cause readmissions. They exclude mental health. I'll show you the criteria that we excluded for readmissions in the appendix. So now just looking, if we were to take a service line level view, you can, when we say service line, we're looking at some types of specific conditions, and then also true service lines like neurosurgery, oncology. And again, if you look at the length of stay index, I'm not going to highlight here, we have in purple where it might be a little bit higher than the comparison groups. Certainly nothing jumps out at me that says, oh my gosh, the one thing that we look at, and we're going to dive a little bit deeper, is just looking on the epilepsy, the 368 cases reported during the time frame was the length of stay was a little bit higher than other CHA hospitals, and perhaps one child may have passed away of those 368 cases, which makes the mortality index probably a little bit higher compared to other CHA hospitals, a little bit higher expenses. But the readmissions for epilepsy were a little bit lower. And then for readmissions, the opportunities that you would see are commensurate with other children's hospitals, sickle cell, oncology, spinal surgery is a little bit higher than others, those 177 patients. And so again, you could dive in deeper into those particular DRGs and conditions to see if there's any reason for that. Now, this is, I think, for opportunities for coding. Again, remember we had said, telling the story that patients are just as sick as other children's hospitals, and the opportunity of increasing the E here. You can see for the length of stay index, you've said it's slightly a little bit higher, 1.07. But in general, you code anemia a little bit lower than other children's hospitals. Epilepsy similar. Malnutrition and dysphagia and mood disorders are a little bit different. Now, I can't tell you, looking specifically at this, to say if you increase those to 6.9, if you increase that to 5.0 and 2.1 for mood disorders, malnutrition, and dysphagia, respectively, that it's going to drop your ODE to lower than other CHA hospitals. But it is telling me that there are some opportunities there. Now, some people say, well, it's playing the game. I would say that that's not necessarily true in information that has increasingly become transparent across the United States. And certainly any executive at your organization would say trying to explain in a 30-second soundbite for the New York Times or others makes it come across as being defensive, and it's sometimes a hard battle to fight. So I would say to avail yourselves where the opportunity exists, and sometimes where we see best practices is actually coders sitting with the quality individuals and just looking at cases, particularly if there's an event, whether it's a readmission, whether it's a safety indicator, whether it's mortality, and just looking at the clinical record versus the administrative record. And sometimes
Can I ask a quick question?
Yeah,
Sorry.
absolutely.
I just was wondering how many of the CHA hospitals also use Meditech? Because if we're looking at diagnosis codes, I wonder how much that is distorted at our children's hospital.
Zero. The answer is zero. I was just texting about that.
Yeah, I don't know. You're right. I'm not aware of many children's hospitals using Meditech, but we do have a number of Meditech users across the United States, more from the adult population. But again, these are opportunities, to look at and putting you in the best light, because I would also argue too, if things are inappropriately documented, you're also relying on your quality efforts that might not necessarily be accurate when you take into context accurate coding and billing. So I think it's important. It's certainly not the end all or be all of quality improvement, but it is an important part. And we at Vizient, do show this data to all our children's hospitals and our adult hospitals as well, to say it's important to make sure that if these are occurring, to document it. Code.
I'm sorry, this is Molly Triplett with Trauma. Could we go back to the last slide just very quickly?
Yeah.
Where are the case numbers coming from?
So the case numbers are based upon final documentation and coding from the bill that you submit. And that's where the diagnoses are coming from the administrative record from the patient, and where the diagnosis was. So what I mean by that is we also have a listing of matching of which DRGs go either separately or go under a service line. So that's important to recognize, because again, for documentation and coding and for databases, understanding the parameters and the definitions is key. So we recognize perhaps that not every DRG might be assigned to the same service line, but we have to start somewhere. And that's certainly something that Christina, as your OQE, and Tennille and others, we can look at. And there are examples on the database in the instructions, if you will, that map the specific DRGs to either their own DRG for peds or a service line. So it can mean that some of these patients, may have been taken care of by the hospitalist, but they had a specific diagnosis that fell under, a different service line. But we have asthma, broken out as its own kind of service line, because we know theoretically it can go to a hospitalist, go to a pulmonologist, go to pulmonary critical care, the ICU. So we use for that and epilepsy, where it could be, again, taken care of by a neurologist, behavioral specialist, developmentalist, or a general pediatric hospitalist.
And does this look at just admitted patients? Because, for instance, trauma sees a lot of patients that aren't necessarily admitted,
Yes,
but are provided care in the outpatient setting.
yes, you're absolutely right. But one of the things that you can do in the report builder, you can pick any diagnosis of trauma, and then you will see more than 364 patients.
Yeah, because that number just, when I'm looking at my totals for Q3 2020 that number is low on this. So that's just what I was trying to figure out where that number was coming from.
Yeah. Again, so this is DRGs that fell under trauma that made this. If you decided to search for, and I'm going to show you an example when we talk about pneumonia towards the end of the presentation. But for report builder, you could certainly put in any trauma, and you might see that number go up to 1,000.
On the 30-day readmissions, when you're looking at those readmissions, is that any child who is discharged and admitted in 30 days, even if coming back for a scheduled.
Yes.
For this one, we did not use scheduled readmissions. I'm hoping,
Say.
Because we don't chart.
We don't chart it
So
as well.
To be a failure in charting as well.
Yes.
Correct, like that, all that HEMONC stuff, I think
So-
is all failure
chunk
to
of it
say,
is.
return for routine chemo.
Yeah.
Right?
so this is where we drew it. It's in the appendix. Sorry for the, it's all readmissions unplanned only. So we factor those. Now, again, if there was a mistake in documentation and coding,
Well, and the clinic EMR is separate, right? So there's no, because it's probably documented in the clinic EMR, but it doesn't talk to Meditech. obviously. So I know, I hate to belabor the point again, but the CHA hospitals that participate also in Vizient, I remember when we saw the list previously, months and months ago, there were multiple hospitals that only shared their newborn and neonate data because their NICUs and their newborn nurseries were inside the adult hospital that participated in Vizient.
Mhm.
Is there a way to specifically
yes.
remove all of those?
Yeah.
Every single one that's neonate and NICU
Yeah.
specific only, because I think there are some codes that are probably included in some of this that are NICU codes, and I think that's a different beast than
Yeah.
what many of us do. I mean, the NICU, I'm sure wants that data.
Yeah.
So Susan, I'm sure wants that data, but.
Yes, you,
But.
yes, and again, I could even, depending on the time, take you live on the tool. But the answer is yes, you can factor out and include those who you want to compare yourself or benchmark out. So the answer to that is yes.
This is Erin Walker. I have a quick question related to classifications, the DRG classification. So my understanding is you utilize MSDRGs, correct?
Yes, that is correct.
So one difference, just for the group to know, is that Children's Hospital Association uses APR DRGs.
Yes.
Right, wrong, or indifferent, when you look at, so NICU is a really good example. They have 29 NICU APR DRGs, and there's 5 for MSDRGs.
Yes.
They're just a lot more granular, which on a pediatric patient allows us to look at things a lot more in depth and do a better dive on those things. We
Yeah.
historically have not been able to get APR DRGs because we need to purchase the grouper. And I'm wondering if you guys have the capability within Vizient to do APR DRG grouping.
Boy, I'm just smiling here because you're spot on. We did have the 3M grouper. They wanted to charge us $10 million, I believe, for a continued license. And we said, thanks, but no thanks. So we do things like there. However, let me go back and say you could also type in ICD-10 diagnoses to do comparisons in the report builder. So you can go down to an ICD-10 level to be able to compare that to get a more granular level. But we use what's called the Vizient acuity scale and the relative expected mortality that is very comparable to the 3M grouper. It basically puts children and adults in categories of expected mortality, above expected, well above expected, below, well below expected mortality. And you could see those REMs on the individual through the report builder and also on the individual patient files. And we found that there was a good correlation between the 3M model and ours that we had to reproduce because of the extra cost there. But you're spot on with that comment.
Go ahead. I've spoken many times.
No, this is all for y'all.
The APR, this is the CHA comparisons then are what, APR DRGs, and we're using a different.
No, they're
number to compare?
MSDRGs.
This is apples to
No.
apples because it's all in this.
Yes.
So you're taking the CHA, you're taking the APR DRGs and pooling them essentially.
I'll explain this. So,
That would be amazing.
so our coders code an MSDRG for everything. OU Health, Oklahoma
Yes.
Children's Hospital coders code an MSDRG for every case, and that's what we send. Because CHA does not accept the MSDRG; they only accept the list of diagnoses, including the primary diagnoses, and
Yes.
list of procedures.
Yes.
So ICD-10-CM, ICD-10-PCS,
Yes.
that's what gets sent to them, and then they run that through the 3M tool to generate the APR.
So, but what they do is they take what we submit, they crosswalk it, like you're saying, they create
Yes.
APR DRGs, and that is how, when you look at APR DRG, or when you look at CHA data, it's all reported as APR DRGs. So like, I think my point is, when I look, if I were to pull up a Vizient database and a CHA database, a FIS database side by side, I really couldn't do apples to apples without some back end work of it getting
Yes.
back into Vizient and turning into something else.
Yes.
It does look like many of the children's hospitals that are members of Vizient are also members of FIS,
Only the academic medical centers.
like we are.
Yeah. Yeah, but again, only about 40 to 50% of those across the United States are handling children. They're only being admitted to Children's Hospital. The other 50% are admitted to non-FIS hospitals.
But we would compare with children's hospitals because we are a
Sure.
children's hospital. So I don't think that the argument that we are missing the community hospitals makes a lot of sense for us, because I think we should expect to be held to a higher standard
Mhm.
than community hospitals, right?
Mhm.
So I think we would probably only want to compare with children's
Absolutely.
hospitals.
Yeah, and you have the ability to do that within the database.
I'm seeing a lot of adults. When I look at it, I see a lot of both. Not necessarily either or, but I do see a lot of.
Yeah. Yeah, and again,
But what from CHA, I cannot tell what is FIS versus what is addiction essentials.
This is Kathy Hunter, Pete Surgery. Just to be aware, though, we're going to find that if we only look at the children's hospitals, the true children's hospitals, we're going to miss seeing how much more expensive we actually are. And although that might not matter to us from just a quality perspective, longer term from an institutional perspective, depending on what's going on with some of the insurance companies, I think we just want to be aware of how far we're outlying perhaps some of our community competitors, even though we don't really see them as competitors.
yeah, excellent point. And this is just, again, opportunities, length of stay by discharge status as far as different routes that children get discharged from. And again, you could see the profound differences in length of stay. And, you know, for example, transfers between other CHA hospitals, and although there are not a lot of patients, SNF and rehab hospitals there, compared to what their expected length of stay. And that really, you know, to be quite honest, in pediatrics hasn't been as large a focus as it has been for adults as far as throughput. There's a profound greater difference in children's care than there is in adult care. I did not look, and again, that could be a potential research project, is to see, you know, these patients, did they suffer complications or safety events due to these long stays? So what came first? Did they have a safety event that caused them, you know, to stay longer, or, you know, were they longer because of lack of services in a particular area that people had to wait, and or did those kids stay even longer because while they were waiting for an alternative bed, they suffered a complication? Again, all potential avenues for research.
So one thing that jumps, can you go back to that?
Sure.
One thing that jumps out at me, I was just looking at hospice patients. I mean, we were 3 times longer length of stay than other children's hospitals. What you see is our observed length of stay actually was a little bit shorter, but our expected length of stay, which suggests to me that there may be some profound coding issues.
There
Yes.
are, we know there are. We've asked for feedback from coding for years and years and never actually gotten any, but I suspect the coders are primarily adult coders who don't totally know how to read through and code our notes,
Yeah.
but we never get feedback about them.
That's one thing.
Can you never even see the final bill, to be honest with you? I never even know it ends up getting coded on any patient.
This
who's
one's
ever
scarred.
discharged.
This one's.
Yeah.
This
Yeah.
difference is scarred
Yeah.
here.
Yep. And then just, again, looking at different base MSDRGs where there's the highest length of stay variance, you could see there. But I just to get an example to dive deeper into just these, high level comparisons, let's look at seizures and just asking, how long are seizure patients staying in the hospital? Well, again, compared to other CHA hospitals, there's a little bit, slightly higher percentage from 3 to 7 days and slightly less compared to between 1 and 2 days and looking at that. And then, where you're looking at seizures, other hospitals that have lower length of stay index, here's an example of some of those patients who are having lower length of stays. And they might be, again, as a practicing hospitalist, one of the quintessential arguments that I always fight with administrators with was, children who had a seizure, do they need an inpatient MRI, or if they're otherwise stable, could they end up getting it scheduled, as an outpatient? And
You showed our graph. I cannot tell you how many times neurology writes a consult note in the ER. It says patient can be discharged home, and the patient ends up on the hospital medicine service for their inpatient MRI. We were just laughing across the table at the graph.
So it seems like stuff that I've been complaining since 1999 still exists in the year 2022. The other one that I actually wrote a paper on is whether or not giving polyglutamab while the patient's an inpatient is beneficial, but that's a different story. So you can see here again, and the reason why we set this up is one of the great members, and we just had our conference in Las Vegas where we had members for 3 days, doing quality improvement projects, and there were pediatric projects as well. There is, we have a very good relationship with these other hospitals, so that if you ever needed to make a connection between saying, hey, you're tackling this, what have you learned? We can certainly, my partner, Steve Muir, and I, or Christina Prees as your OQE, can certainly help you with those connections if you need to. So again, and I think the pediatric robustness of these quality improvement projects are only going to improve throughout the years. So for just example, now let's take readmissions based on that as where, you look at between hospital-wide readmissions, again, non-planned readmissions and all, where the spectrum is occurring from. And, what I'm sure all of us in quality recognize that usually within the first 7 days, readmissions are related to the reason why they were in the hospital, versus those between day 8 and day 30 are more related to the underlying chronic condition. And it was interesting to me, it was just published, I think, a day or two ago in Hospital Pediatrics that looked at discharge summaries and quality of discharge summaries. Where I was at before I left in 2020, there was not one discharge summary that I would consider a well filled out discharge summary. Hospital Pediatrics, they concluded that about 25% of the discharge summaries were still missing key information, that they were written at a language at the 10th grade level, which, as we know, we're asking for a 5th or 6th grade level because of health literacy. Follow-up appointments, people not necessarily.
Discharge summaries or discharge instruction?
Discharge instruction, sorry. I meant, yes, sorry. Thank you for the clarification. Discharge instructions. So again, still have lots of gaps. We don't do teach back as formal standard work. We're still seeing it's more profound in adult hospitals as far as 7-day and 3-day readmissions, but you can see it's not an insignificant number when we look across the United States. Just a different way to look at by a payer segment. When we're looking at here between Medicaid, commercial insurance or self-pay or uninsured, just differences as well in readmissions. And you can see for other CHA hospitals, there's a difference between commercial, private versus Medicaid, and we're seeing the same difference at Children's at OU as well. What about race as well? We're seeing here that typically what's interesting to me is that you don't see as much of a difference between African American and say Caucasian in children as you do necessarily in adults here. A slight difference, and again, I didn't analyze to see if this was statistically significant, but slightly higher in African Americans than in whites. And we do see that Asians typically have lower readmission rates than whites and adults, and we're also seeing it in CHA hospitals as well. And when we look at 30-day readmits, if you want to again step back and look at just specific base index MSDRGs, you could see the differences in 30-day readmission rates for the different DRGs compared to CHA hospitals. And there's, I wouldn't say stark, huge differences, but potentially some opportunities to dive and take a look at. And then when we're looking at different lowest 30-day readmits, here you can see the data, although some of them are not necessarily full-scale children's hospitals. Now, when you're looking at cost variance, again, you can see the difference, and again, what potential savings are. And we put this potential because there's a lot of caveats to that. But when you look at spinal fusion, there are differences there, and there's a potential $1 million gap there between observed and expected. Again, if your cost accounting system here is not showing that, then obviously you're going to go. But it won't be one that I'd want to look at these top three conditions to see, again, if there's a coding and documentation issue and opportunity, or it's just the cost methodology that differs from what was input on the CMS cost worksheet versus your own internal accounting. But I think that the point was well made earlier that typically children's hospitals do have a higher cost structure than non-children's hospitals. And you could even break down, physicians love this, as far as cost by provider by service. So again, looking at different variations in costs, we de-identified the cases that were done by by the surgeons who were doing spinal fusion. You could see the different numbers there. And one of the things that stands out a little bit is the pharmacy. The cases, the 1, 3, 5, 6, 3, 1, 9, 8, 6, 7, the 9 cases. It's a little bit higher pharmaceutical costs than some of the other physicians. You could see the majority of cases you would expect in implants. Although it does seem your cost for implants is a lot higher compared to other CHA hospitals. That might be something to involve supply chain on. Are the surgeons using a vendor that isn't a preferred vendor for OU Med, and therefore their costs are a lot higher compared to some of the other CHA hospitals? So again, partnering with supply chain and surgeons to allow you to take a look at this. And this is, again, where patients are located. We could certainly look at ICU versus CCU and general medicine floor. We're seeing that spinal fusion, there's a higher percentage of those going to the ICU, CCU compared to the intermediate step down compared to other CHA hospitals.
Now, as you are doing your customer surveys, you guys specify which type of methodology that they're using from a cost accounting perspective? And are we able to get down to that level as far as our peer group can match the specifications? So like if Children's versus Kansas City is utilizing the ABC versus an RCC based methodology, are we able to get down to that granularity of a peer group?
You would be able to see, yes, their level of cost for what we're looking at, yes. And you can also look at, you can look at implants, but I don't know, and the cost of implants through the resource manager in the CDB, I don't think you can see the product name. So it's really, I think, what I would do from this, if you were interested, is just saying, you know, if the products that surgeons are using are on the preferred, list, or they, using products that OU Med might not get a discount for supplies.
So because the cost should be directional,
Mhm.
however, allocation methodologies.
Yes. Yeah. And then again, I'm not going to spend a lot of time on this. It's more just, utilization and compared to other children's hospitals. So again, we focused on spinal fusion here, and they use more blood gases than other CHA hospitals. They also did, and I don't know if this was part of screening. It seems like it might be a formal part of screening about using coronavirus testing compared to other CHA hospitals. Bicarbonate levels are a lot higher. Lactic acid levels are a lot higher. Creatinine, calcium, BUN. Some of these might be standing orders. CBC's at 98.99%. To me seems more standing orders. And again, not probably going to be your top focus for quality improvement metrics, but again, showing you that there are variations and differences and things to go after. You guys do very well in our pediatric safety indicators. So, the one that was a little bit different was the birth trauma. One was a little bit higher observation rate per 1,000 cases for CHA hospitals. And again, if you lowered your comparison group to other children's hospitals, it might be commensurate. With them. But what's interesting to me is we see the same thing in adults. Is that when you have a complication, you typically have a higher length of stay, and you typically have a higher mortality rate. And so again, that improvement in cost of care is potentially efficiency can promote effectiveness as well. I wanted now to go in the last two topics to talk about is using population health and how this can potentially inform your metrics. And we're having Christina work on this to get for OU Children's Hospital and OU Med, because they could be different because children's hospitals typically have a larger geographic variation. We've constructed through publicly reported data, and we're actually updating this for next year. This is our previous iteration of these 8 factors that exist within your community to see how that might impact outcomes. Now, we know that right now CMS doesn't adjust for population health metrics and socioeconomic status. For the readmission penalty, they do group hospitals together, and what they found out and reported was those hospitals that were grouped in more challenging socioeconomic conditions paid less of a penalty. The problem that I see with CMS methodology, and where I think we're going to see in the next 5 years, I think we're going to get better social determinants of health data in EMRs and in administrative records, and there's going to profoundly show a difference in those patients or hospitals that take care of more indigent patient populations. And I'm going to show you an example here, but these are the domains that we look to construct. And this was where I was previously a CMO at. have a big affinity for the underdog and disadvantaged patient populations. And what it's basically showing you is the orange and deep red are 2 to 3 standard deviations lower than the mean for those 8 determinants that I had shown you at. And it could give you a percentages of patients that you're drawing from those particular zip code areas. So you can see we had a very little pocket of affluence, but unfortunately it was very low percentages here. And the majority of our patients had either anywhere from 0.5 standard deviations to 3 standard deviations below the mean when it came to those different eight numbers. And why this is important is that you can then map some of your patients to these geographic areas to be able to see what their outcomes. So for children at OU Med, you know, those kids who might live in impoverished areas, who might be coming back more with asthma, or who may have worse outcomes for sickle cell, for example. And what we had found, at least for adults, is in that affluent pocket, it only took 3 days to get to a scheduled follow-up appointment. In those areas of deep red, 35 days. And it correlated to 1 out of every 10 of our patients came to the emergency department more than once in a 30-day period. And it was predominantly from that area that had a 35-day wait to get into primary care. And then with bringing in utilization records as a qualified Medicare entity, you can construct those patients from a population health or are using those more resources. What I'm looking for, the Holy Grail, is the 5% of patients that expend 50% of the resources in doing competitive advantage in hospitals and outcomes, and that 5% that occupies 50%, instead of building more cardiovascular towers and neuroscience towers and oncology towers that pay the bills and try to reduce the number of patients who lose money based on their Medicaid reimbursement status. Let's talk about CDB as far as research opportunities. So I just wanted to take 3 high levels of where you can get this. One is just variations of drug usage in clinical conditions. So I did this morning at the AC Hotel. And so what I did was, you guys are a little bit lower on this, but all I took is all the CHA hospitals, and I did the ICD-10 codes for every single viral pneumonia, whether it be human metapneumovirus, whether it be RSV, whether it be, I excluded influenza. So influenza pneumonia isn't here. And I looked at how many of these patients who had viral pneumonia had antibiotics. 2022, folks, 13 to 100% of patients who are viral pneumonia are still getting antibiotics.
Can you break
kids.
that down by how many doses of antibiotics they receive?
No. You can look at IV versus PO, but burden of dose, no, you can't specifically look at that. But you can certainly look at through your own EMR and match that up to see how many they receive.
So even if they get a dose in the ear, that 1 dose is counted.
Yes. So again, year 2022, 13 to 100% variation.
Is it counted the same if the antibiotic is prescribed for something secondary?
It's so it just looking, so that is a potential confounder. Yeah. Again, I don't think in all these patients but they were all, their primary reason for being in the hospital is viral pneumonia. So one of the things that we looked at, and this was from the adult side, is, and what we're trying to get on the pediatric side, we did a large initiative on reducing mortality. And we had 34 members in our cohort that were using the CDB in the upper Midwest, so around the Minnesota area. 17 of them decided to partake in the initiative. The other 17 that did it was a natural experiment. We used the Paris framework for health outcomes to do the project. And basically what we had found out that after the intervention period, those who went through the program had a statistically significant higher improvement or better in mortality than those who didn't. And it wasn't just increasing the expected, it wasn't just documentation and coding, it was also in the observed. So within our Q&A rank, they experienced a relative 21% performance in their Q&A rank for mortality. So as we think about, doing larger scale projects in pediatrics, there's an opportunity as well to look at that. So the one thing that that I wanted to look at that I have a big interest in is equity in the population health. And so I decided to look at how many patients are labeled non-compliant in the CDB. And this, I decided to look in 2019 before COVID started. And there were over 8 million patients in the database at that time. And I was just looking for the Z codes of non-compliance. And 6%, so almost 500,000 patients had a code for non-compliance. And we all know the pejorative nature of non-compliance, what it's associated with. And I wanted to look at variables that were associated with non-compliance. At that time, only 12% of patients had a concomitant social determinant of health, anywhere from Z55 through Z65, whether it could be poverty, there's things in there about noise pollution. I mean, it's crazy. There's about 99 different variables in there. So they would get credit if only one was coded. And only 12%. Now the federal poverty rate is about that, is about that level. So we know that social determinants of health are undercoded. But the thinking is that when you code social determinant of health and you can explain why patients may be non-adherent, you're going after factors that you could potentially correct rather than labeling patients and their families non-compliant. And what we had found out that yes, using those who had a social determinant of health, when we did multivariable regression, we found that they were 4 times more likely to have a non-compliant code. So rather than using non-compliance, let's use social determinant of health, use case management there, and you could find those 5% of patients who cost 50% of the expenditures. Unfortunately, patients who were African American was the second highest variable there. They were 2 times more likely than Caucasians to be able to be labeled non-compliant, which if you're charitable brings up implicit bias. If you're less charitable, and I would argue more accurate, is systemic racism. And so you can see the differences there, how health conditions impacted your non-compliance, your race, unfortunately. And the other neat thing that we did was we used economics across the country to say the most affluent versus the most disadvantaged patient population. So if you lived in the most 10% affluent of areas, your likelihood of having a non-compliance code was 3.8%. If you lived in the most impoverished area, 11.1% were non-compliant. And so really, as a correlation, non-compliance correlates very well with poverty. And so with that, I'd like to stop and entertain any further questions or dialogue.
There are a number of questions in the chat that those folks want us to address.
Sure. So,
Can you see them on your screen?
yeah, let me pull them up. So okay. So when you say manipulating variables, is there a concern for increasing our bias, distorting our results? How is that regulated? I'm not sure.
Related to the slide, not the database itself, but the kind of calculator where you can do some predictive modeling based on changing variables.
Yes. That is just based upon, and I don't know the internal logic for that. All it's doing is saying you have the data in the database, you have your performance. So you're saying instead of if you're less than one standard deviation, if your one standard deviation is worse than the mean, how does that impact if I change it from one standard deviation down to 0? And it does the calculations and says that's what your improvement would be. Again, that's not taking into account rate of change. If you're faster, you'll do better. If you're performing worse, it won't show that. But all it is, it's a static calculation.
I think the important thing is it's a tool you can use.
Yes.
But it won't change your rankings or
Correct.
anything else in the system.
Correct. Great question.
Even the calculator, they call it a what if, right? So it's a what if,
Yes.
right? So I can say, what if I decrease our Z code?
Yes.
Score from 2.3 to 1.
Correct. Yes.
What does that do to our ranking?
That is correct. Well said. Do we have a pediatric? Yeah, we should have. Well, again, we take what you code and you match. We match with the medical office or the CDB coordinator, physicians and DRGs to the specific MSDRGs and also to specific service lines. So if you are doing transplants, yes, there should be a pediatric transplant. There could be pediatric data and pediatric transplant there.
So what you showed, that slide was just an example of some of
Yes.
them,
Yes,
right? It's not
exactly.
all inclusive.
Wow, wow, can't wait to see that. That's awesome, Eric. Yeah, you should be able to get that data from the CDB. Yes. Is it Dr. Endacloglu? Yeah, so they should be in, yes, absolutely all transplants should be, as long as they're documented and coded, they should be able to be retained.
Yeah, sounds great. Thank you. Nice to meet you all. Would you be able to pull that section of the report if it's available there, or email when you guys get a chance, specifically the pediatric transplant quality report?
Yeah, I don't have the data. Tennille is gonna give you the thing. We could work on, I could send an email to Christine Freeze, your OQE, and see if we can run that if you're interested in your next touch base.
Oh, yeah, absolutely. We should continue doing that. So you can email me whenever you get a chance. That'd be great.
Absolutely.
Thank you.
Sure. Anything else that a women's data separate from adult and peds? Yeah, it again, it depends upon how you are who are presenting it, but the women's data should typically be under, if they're over 18 and they're going through the children's hospital, there could also be set by unit. So if there's a flag in unit, sometimes you can get data from a flag in unit from women or NICU. Do you guys how is that?
So our women's services are grouped together with the OU Children's Hospital.
Okay.
Like if that gets submitted, so you just use the pediatric page.
Yes.
Kind of, sometimes,
Yeah.
not always, but yeah. You can filter on the service line to the obstetric service line.
Yes.
A variety of ways to really tease out.
Yes. Thank you.
How are the service lines defined? Like, do we have a list of attendings that are attached to each
Yeah, it's a
one,
great-
or
great
how?
question. So the Vizient service lines don't take into effect the physician involvement, the specialty at all. It's purely DRG with some remapping based upon primary diagnosis or primary procedure. So
Okay.
like if the patient's a primary diagnosis, if diagnosis number 1 on the claim is a cancer diagnosis, they remap to the cancer service line.
Okay.
For example.
So just,
But we do submit discharge physician and discharge physician specialty, and we submit the physicians that are involved in the care, so you could slice it by the specialty of the physician. So if you want to say, we only want to see, and we can also group specific physicians. So if you want to say, I only want to see the outcomes for the patients who were admitted to physicians or my hospital medicine service.
Mhm.
You could do that.
there's a way to do that.
Yeah.
Okay. I was just thinking, like, for epilepsy, obviously neurology is involved with those, but they're admitted to our hospitalist teams. There's a lot of overlap in some of those things. It's just one example, but
Yeah.
okay. So sounds like we can do some breakdown by attending groups.
And I'm so glad, again, being a relatively resource-rich organization and having just, brilliant, talented people, not only clinicians, but administrators and data analysts. What I would encourage is sitting down like this and sitting down with your PEDS team and find out, from a quality or balanced scorecard perspective, what's important to you from comparison groups or looking at the data. And Christine and I could help you, with that and report off that. And we're really making a concerted push to highlight some of the work that's being done in children's hospitals. And I know Primary Children's in Utah is really trying to step up and do that. Johns Hopkins and All Children's down in Florida and Maryland are starting to do that. We're hoping, again, is to bring in Nicholas Children's Hospitals to really, again, work with you and to be able to highlight some of the work that's being done to improve pediatric quality on the PED side. So, and hopefully, although Steve Muir, my colleague's a PhD in background in children's hospitals and worked as a pediatrician. So we're really excited to be able to partner with OU and others to be able to advance the care of children. And again, it's just been my honor to be here to be welcomed to such a phenomenal campus and Children's Hospital, and your engagement and interest here was just awe-inspiring. So you really improve the quality of my day and trip by these excellent questions and how you're thinking about improving care. It makes me proud to be a pediatrician.
I have a quick question. So I saw that you had like CLABSI rates and
Yeah.
CHA. How far can we go back to get those benchmarks?
So the data that I had seen in the typically I've ran data from Q4 2018 up until now. Now I don't know, that was a little while ago, but I think you may have up to 4 years if your data was loaded for them. Some organizations that just started loading, we asked for 2 years in arrears before they come on board. So if your children's data, you can theoretically go to the report builder, and I think it was from 2018 and before. And another research project that we're working on is looking at inpatient falls. It's more so for adult medicine from the Beers criteria of how many people are still using diphenhydramine and Benadryl in hospitals. And it's still one of the top 3 drugs that are associated with inpatient falls. It's spectacular in a negative sense of data that we've known since the 1980s, that we're still doing things that we know cause harm.
I think this is probably, Todd, more for you and maybe for Dale, and I think it's to what Dr. Edens is saying in here. We obviously have this database that's rich, and I think a lot of what was presented today, I can sit there and tell you some of the whys behind it. Like we've looked at a year's worth of readmissions and some of this, and a lot of it does revolve around documentation. Is there system resources to put behind fixes for some of these? Are we like, children, you're on your own, here's your problems, fix them with what you've got internally? What is that gonna look like for us over here?
Yeah, so I think there will be system resources to work on this, particularly from the data analytics. And of course, Stephanie, we're gonna want you in this database.
Yeah.
We're gonna want.
I mean,
your
you've got good quality leaders, for all
Right.
around.
So we know you do, you've got a good system, so you'll have access to the database, so you can go in and create your own reports and look and see where there are opportunities.
So I mean, will there be new system resources to help us with coding and maybe to get us some feedback around
Coding is one that we're actually
coding?
doing an audit right now, so we actually have PwC in an audit of both documentation and coding. I want to highlight that everybody thinks that Epic's going to fix that.
No, it's only as good as what we put into it
But I
still,
think it would be
but
helpful to get feedback about, if you had documented this, or
Yeah.
this
Yeah.
would have been coded. I have never even seen a final bill on a patient that I've taken care of, not one time in the 20 years I've worked at this institution.
I don't think anybody.
Period. So I think if there's no feedback ever, then there's never any opportunity for improvement. And then when you try to have a conversation with the coders and billers, they can't even tell you what's missing
we
or what
speak
they
different
thought about
languages, for
coding.
sure,
It's
but-
just, it's really stunning. And so I think, when you look at what you pointed out, Dale, the difference between comorbidities and things like that, it's quite clear that we have a deficiency there, which probably affects us on multiple levels, maybe more here than on the adult side. I don't know, maybe a little bit more straightforward for adults, or at least there's more focus perhaps on the adult tower, because usually adult towers are more profitable. But I don't know, like, how do you fix that? You clearly are going to have to educate and give feedback and maybe hire some more coders for specifically children. So hopefully the audit will specifically focus on children's, and it's not just looking at sort of the adult tower and some.
Yeah, the other thing, Joe, I've seen it for the adults, about the most commonly missed
Yes.
diagnoses that have. I assume there's a similar list for children. So one of the things we're doing on the adult side is we've identified the most common risk adjustment. Now, risk adjustment variables vary by diagnosis, so it's not one group, but there are common ones that are frequently missed on the adult side: malnutrition,
Fluid and electrode abnormalities,
DNR,
renal failure.
some that are very heavily weighted in terms of the risk adjustment. So we've actually got our coders looking through right now to understand that, but they're actually going through training with Vizient also. So we do that. One other question, Joe, is so for the adult and for our community hospital admin, we've received the Q&A report. We didn't receive one for children's. Is one coming? You presented a lot of data, but will there be a Q&A?
I have to follow up with Christina as to why that wasn't occur. I mean, there is. Let me pull this up, because I did have a slide on what triggers for the report.
I was looking at malnutrition. I suspect our adolescent medicine kids are the only ones that really ever get a malnutrition code on the
So
side.
I think it's
But
probably
I
completely
think
different.
our failure to thrive kids, it may matter for them, you know, well, sometimes I get queries. I get queries about it, but yeah.
So this is the Q&A eligibility. So the fact that you had 10 months of continuous CDB data in 2022, excuse me, and the following two isn't going to be a limitation for you, because your 3 pediatric domain scores, you clearly have enough volume, and you are certainly one of these hospitals that can be included in that. So you're right. When I looked to pull that up, it's specifically your scorecard wasn't there, and I don't know why that is, but I'm going to work with Christina.
There are certain indicators that we missed on the data submission. Most recent data submission was just done just a couple of weeks back.
Oh, so you're
So
expecting.
I think she's estimating for some time in late November, December, as far
Thank
as the
you.
pediatric.
Thank you. Again, I think it's going to be really interesting, and I'm really passionate about social determinants of health, and I think that there is going to be, once, for example, over 33% of the United States has impairment in health literacy. Within our database, it's coded less than 1%. And I think as we get more and more of that data, the other interesting thing is when we look at the top US News and World Report hospitals and where that Vizient vulnerability index is, 8 of them take care of a more predominantly affluent area. And that was brazen enough because I'm old. But I asked my colleagues there for chief medical officers. Becker's had a report that said, imagine if more patients in the United States had the opportunity to be cared for in these top US News and World Report hospitals. What do you think the outcomes would be? So I reversed it, and I asked my colleagues off the record, would you still be a top 10 hospital if you had to take care of a more predominantly disadvantaged patient population? And to their credit, they said no. And I just see that the amount of community hospitals that have closed in the United States, where people have to go further now for care. And I just wonder if in 5 years from now, when it becomes standard to say, of course, now social determinants of health makes a difference, whereas now everyone's arguing that it doesn't.
And there's going to be more and more of a press for it with the new Joint Commission standards that go into place on January 1st.
We're actively working too with CMS. We've shown them our risk methodology, and we're including broadband access, which may be an issue for places, more rural areas as well to get care. So I think you're going to start seeing more of these social determinants of health being integrated into the data and getting better risk models. Because again, if you believe that they say, as far as health outcomes are concerned, medical aspects of health, there's only about 20% responsible. So we're missing the other 80%, whether it's genetics, whether it's behavior, whether it's those other factors for outcomes. And we're, really still focused in the acute medical care.
Assuming you guys take into account the area deprivation index that University of Wisconsin has.
Yeah, we've used parts of the ADI, we used parts of California's, we've used parts from other agencies, and the ones that we came up with, this was the model that seemed to have the best predictive value.
Is there details somewhere about how that was
Yes.
built?
Yes.
I like that because ADI as an example, it's free.
It's a good one, actually. That's what we use for most of our research on mapping.
Yeah, this has the ability, it's zippable, but we do have the ability to take that census tract level, which is anywhere from 800 to about 3,200 patients. So yeah, to get down to the street level.
I know we're talking about children's, but as Dr. Atkins knows, fire on the adult side. Few days now, so really got distributed. People really looked at it, really started asking questions. Matt and his team are being inundated now with requests for additional data. So, prospective training people in the organization to be able to use it. Take a look at the data yourself.
Yeah, I know some organizations, and I'm not pressing for this by no means, but Kevin Sowers, who used to be at Duke now is at Johns Hopkins, uses this as their physician, to bonus and incentivize their administrators and their physicians. So there's a lockstep understanding. I feel like I'm a de facto employee to Johns Hopkins because obviously they're tying their performance to the Q&A in this. And again, it's every database, as you know, has its limitations. But I think the important thing is no matter which one you pick, to actually use it for quality improvement and not get paralyzed by analysis.
Yeah, so, Stephanie, she's a real champion for quality and safety. Real champion on the children's side. And I think the one thing that I want us to, I think we really do have some documentation coding issues. I think we're all pretty convinced we have some documentation and coding issues. Not completely convinced that we're fixed with that, but we have some issues that we're working on now. And I think we can move rankings based on fixing the expected.
Absolutely.
I think we also have to acknowledge that we have opportunities to improve.
Sure. I don't think any of us would say differently.
we all
So-
know that.
No.
It's just in the past when I routinely sent out these reports, it always got back to coding and documentation.
No, I think we have questions about the data sometimes because we want to understand what definitions are and how it's pulled and all that. But I don't think any of us here at Children's sit and pretend that we're living on a white house at the top of a mountain and we're perfect. And there's not a lot of work to
I think
do.
we're 2 feet in on quality improvement. I think it's important to have the right data and the right comparison.
Yep.
I think those are the things that are paramount in my mind, and without the right tools, we can work as hard as we can, but you're not gonna clean the floor with a toothbrush very efficiently. It's just not gonna work out. And so I want to make sure we have the right pieces in place before we just jump in and try to work harder. Because we're already working pretty hard.
Yeah, so one thing on the adult side, Vizient Christine actually provided some information to us. Is, we had just under 200 people that died in the adult town that were coded at very low risk.
Yes, yeah.
So we could quickly identify.
Yeah.
So we'll pull, get around, pull that list so we can actually look.
And that's a great point, because we also have a mortality calculator that could show you from coding and documentation where adult hospitals are looking at. They're just, not looking through the quality director where you see an 85-year-old who had metastatic cancer, was in the ICU and died and moved on. They're actually looking at their risk of, what their expected risk of mortality was. And I remember going to Cheyenne, Wyoming last year, and we looked at one of their patients in these low risk databases, and actually it was such an opportunity for coding that if they captured everything correctly, it would have been as high as 80%. And that really lit a fire under, people to say, how important documentation and coding is. Again, it's certainly not the end all or be all, but I would argue that focusing your quality efforts on things that aren't appropriately coded and documented may lead you in a different direction than if all that was, under control. If you're looking at it as a control chart, and be able to focus on the things that really, involve quality improvement.
And I don't think Epic is the fix to anything. I think we could do a lot even with Meditech, what we have right now from a documentation and coding standpoint. Epic's not going to be any better than what we put into it. I mean, it will be better, but it's still going to be really people dependent on what we put into it. So for sure. Okay.
Yeah, and I hope again that we start developing our pediatric stuff and models just like we do for the adult side on the ped side, that it gets even more robust and even better. But we're trying.
Yeah, Dr. Geske, thanks so much for your presentation. I think what we've been talking about now is kind of retrospectively looking at the data and using the data kind of in a lag fashion to make changes. But what about in real time? With Epic? I know Epic isn't the cure-all, but with Epic, is there an opportunity to interface with the data that's being connected with, and actually use that as a prescriptive?
Great point. Great point, Andrew. We have been having conversations about incorporating more of that real-time feed from EMRs. I don't think we have a specific plan of doing that yet, but it is on our intention. We are developing as well APIs to be able to use, to derive even more benefit from specific uses of the data and reporting. And like I said, getting more of the social determinants of health in and getting the utilization in will help improve population management. But I think you're right. Our goal, our mission as a company is to drive to those current standards and embed both the clinical data with the administrative data to have a more comprehensive picture. Again, for the AI stuff, and we're looking at, AI, at least the preliminary results of some organizations that are really getting real-time data into their clinical unit, into their clinical units and reporting. It's really causing a lot of consternation from physicians because, for example, if you get a respiratory rate now that changes somebody's sepsis risk from 0.7% to 2.3, and then if you wait a few hours later and you get another variable, at least we haven't been able to operationalize that to give it its biggest utility, because some of the organizations that I know that are piloting this, it's setting up separate teams that are reacting to the data. So I think we're going to see more and more of that yet, but I think for its clinical use, that real-time data, it raises just as many questions as well, because you're talking about potentially, utilization patterns that may have been altered, where your sensitivity might go up significantly, but your specificity goes down, and you're expending more resources, and you're not quite sure what the long-term outcomes of that have been. But there's no doubt having more of the EMR related data can definitely could definitely help in quality improvement, and we're getting there.
And we do have plans in place right now to bring data from CDB into our data warehouse, to where we can start incorporating it into our Tableau dashboards if that's what we needed.
Yeah.
In addition to that, this preparation is part of Epic, we do the same thing. So as you start integrating with reporting into Epic come March, we'll do some training for a wider scale part of the organization. We'll have plans to integrate also CDB benchmarking data, where you can do some comparative analysis too. So
Great point.
plans are in place, just waiting on contracting, right?
All right, thank you.
Thank
very
you,
much
everyone.
for
I
being-
appreciate it. Thank you.